You are listening to the global network of podcasters dedicated to the pharmacy profession. Welcome to the Pharmacy Podcast Network.
And welcome to Pharmacy Technology and Management Review's Direct Access interview series. Today we welcome Hamad Shah, CEO of Clarist Health. He's a pharmacist with a variety of experience in the pharmacy industry, and he talks about Clarist Health's mission to deliver high-quality, personalized medication management to patients in long-term care settings. We talk about how Clarist Health goes beyond traditional pharmacy models. They focus on risk stratification, identifying patients most likely to benefit from personalized care due to medication adherence challenges, adverse events, complex medication regimens, patient engagement, and how collaborating with patients and their physicians to develop a holistic plan can address medication needs and goals, and evidence-based guidelines, how Clarist uses algorithms and clinical expertise to ensure medication therapy is optimized and aligns with best practices. I hope you enjoy the interview.
So my name is Hamad Shah. I'm a pharmacist by degree. I grew up in Philadelphia, went to Temple University Pharmacy School, and have spent most of my career in pharmacy. Spent the first decade of my career running retail drugstores, then was in the PBM industry for about a decade. And the third decade has really been more in private equity-backed organizations. And but most of the time focused in and around pharmacy. I think with that experience that I have, I didn't just see pharmacy from one angle. I've seen it from multiple angles. So hopefully it gives me greater knowledge about the space. And you wanted to ask about ProCare. Oh, sorry, go ahead.
Well, this is actually just interesting. So I live in Philadelphia. We're in Bluebell. Okay, so thank you for sharing us, giving us a little bit of your background. And I guess let's just jump into understanding more about Clarist and the clinical programs and how you aim to address the highest risk members. And I'm curious what that looks like. When you say highest risk members, what does that mean? And how does this differ from traditional models, pharmacy models?
Well, look, I think the traditional pharmacy models are more, somebody's got a prescription, let me fill that prescription, let me make sure it's accurate, and let me get it to them. We work in many different ways, and we have different tentacles in the organization. So one of the things that we do is work with payer organizations to take their patient population and risk stratify it and say, who are the members that are really, we think, not adherent to their meds or have challenges in terms of adverse events or risk events related to med therapy, maybe aren't on the right meds altogether because they've got 4 different physicians they're seeing and they're going to 3 different pharmacies to try to get the best price on meds. And somewhere in the mix there, they're really not on the optimal therapy. Mm-hmm. So we are not in the business of just sending meds to the patient home and saying, our job's done. We're having them pick it up at retail and say, any questions? None? Good. You're on your own now. We really want to be engaged with that patient to make sure, again, right therapy, right set of drugs and compliance and adherence. And we have other programs also, but you asked how we differentiate. And I think that care, that engagement with that patient to ensure the right therapy, and not just the patient, but their provider also. So we go that extra mile to make sure those things are done well.
I think that this idea of personalized care is what you're talking about here. And
Absolutely.
I guess, when you talk about personalized care planning, which I think is interesting, you're talking about working with the patient and also working with the physician. And that, a lot of times that comes up as like collaborative care. And I guess what are as you see it, the impact that has in improving quality of life for the patient and outcomes as well? Being able to keep everyone on the same page in that way and looking at specifically at that patient and their issues that might come up from their lack of adherence or Yeah, I guess lack of adherence would be the main example
Well,
here.
let's start with the personalized care planning and how it starts. So we get pharmacy claims, and again, we get them from the payer, right? We get the medical diagnosis, and then we interview that patient, and we really jump into the details to validate the things that we've seen in the claims data. Sometimes it's not accurate, right? Sometimes patients are getting cash meds from places and it's not showing up anywhere. In addition to that, there might be OTC meds that they're taking and they don't show up anywhere. And even in the physician's data and the EMRs, those don't show up because the patient forgets. And then when we take that information, we have algorithms set up in our system, and they look at medication related problems that we may identify and ranks them highest to say, okay, well, look, these are clear, glaring things that we're seeing in terms of med therapy that need to be addressed with the patient. So our caregivers have that information in front of them before they do the interview process. In the interview process, we also intermingle the goals that the patient may have. We try to find out a little bit more about that patient. Are they having challenges, or do they have certain priorities in their care plan that we can incorporate in? And once we've got all of that done, we've got a holistic plan that now we can reach out to the different providers that they have if there's adjustments in therapy needed. And how we see this manifest itself is that the patient feels that they're a part of that plan. And when they're a part of it and they've got ownership in it, they're more likely to be adherent to that plan. In addition, what we see, and we've seen this in data, is fewer hospitalizations and fewer visits, right? The physician can only do so much in an acute setting. When you go visit them once every 6 months, once every quarter, if you're not taking the meds properly and if the fundamentals aren't right, there's nothing that the physician can do for you, right? So we really focus on those care needs. And what we've seen is a reduction in cost, because if there's less entry into the hospital, there will be a reduction in cost. If there are less acute procedures or things that need to be done because therapy wasn't right, there'll be a reduction in cost. And the patient feels better. So those are the things that we think really matter in terms of outcomes.
And the kind of patient you're talking about is a patient on multiple meds, correct? We're talking about a patient on multiple meds or with a complex health issue that is not easily managed by a twice a year visit to a doctor. This is an ongoing health management issue for this patient.
You're absolutely right. Look, I put patients into the spectrum. That's how I view them, right? They're all the way on the left are folks that, are relatively healthy. They're maybe taking a med or two, maybe taking a cholesterol med, but there's not much we can do there. I mean, they just got to take their med every day, and that's that, right? In the middle is the general population where there are some issues, but overall, they're pretty well contained, and we don't see an opportunity for intervention that will yield a real benefit either to the patient or to the payer. Then you think on the right-hand side of the spectrum, and these are the patients that are constantly in and out of hospitals, or it's not just hospitals. Think of it as the coordination of care in a post-acute setting, right? They may go to a hospital, then they may go to a skilled nursing facility to recover and to rehab for a bit. Then they may go home and they may transition again. So it's this constant rotation, which is increasing cost, but it's also really impacting very negatively the health of that patient. They can't get settled anywhere. They're constantly transitioning, and it's a big burden for them, right? So we really look at all of these things that are impacting the patient. We look at that patient in the bottom right of the spectrum as I defined it. These folks may be on 6 to 8 different medications. They may have 3 to 4 different comorbidities. They may be visiting a neurologist, a nephrologist, a cardiologist. And as we know, those physicians, as great as they are, they're great in their space.
Right. They don't talk to each other. Right.
They don't. Right. And their records don't, interact. There isn't someone that is an advocate for that patient other than caregivers. And if you look at the caregivers, if it's a son or daughter, if it's a husband or wife, many times their healthcare literacy isn't to the point where they can really question. So that's where we step in. And we think this type of service is critical, in society today. And we all know, based on information that we've seen, that it's that right of the spectrum. It's those few patients that are really the ones that need this help.
They're the ones when they talk about, and I don't want to throw out statistics because I can't, I'd have to look it up, but those are the ones that are the highest costs.
Yes.
They're the most expensive patients. And so not only can you help them, clinically, but then you can also help financially, because if, like you're saying, you don't have these lapses in care or duplications of care, by tracking and having all the information in one place, everyone's going to benefit. The system benefits, the healthcare system benefits, but the patient benefits as well. So it helps in multiple ways. And I guess that's interesting, because one of the questions here that I wanted to ask, and I'm curious about this, when you talk about this evidence-based guidelines for the clinical programs, I feel like that's kind of what you're talking about here, right? This idea that you're looking at all this data and you're able to develop programs that will help the patients.
I absolutely agree. So I think the fundamental basis is the evidence-based guidelines. There's a lot of literature out there. It's difficult because it's changing. There's more information coming out all the time. And we have folks that are clinicians whose job it is from morning to night to really be monitoring and managing the information that's coming out on therapy and on medication management. And they take this information and embed it into the framework, into the algorithms that we have. So the core of this is evidence-based management, right? And those guidelines are critical to what we do. So absolutely agree with you.
And how did you, as you develop that, as from a company standpoint, when you see there's a need here, I guess what's the background? Like, what's the background that goes into deciding that's the way to go with this? That you want to look as much data as possible, and hire experts, like you're saying, like pharmacists and clinical experts who can then evaluate it in an effective way. And then I assume using AI and other technology to process it to create the framework that you're able to implement.
Yeah, look, I think, when we started this, I think you asked this earlier, how did this begin and how do we get to where we are today? We started this with a couple of institutional pharmacies, and we really took care of those patients that were in nursing homes and skilled care facilities, right? Skilled nursing facilities. Over time, we saw these opportunities to say, look, there's just a lot of patients here. They're coming in and out. And if we just hire pharmacists to sit there and constantly be looking through information and paperwork and data, it's really not a great use of that pharmacist's time. A lot of this stuff needs to be standardized in some software with some algorithms. And based on that pharmacist's knowledge and the clinical and evidence-based guidelines, things should be highlighted for them, right? These are the things that we need to focus on based on the information that we entered into the system. That's what we've done. So we needed that capability. So we went and purchased that capability in the form of a company that had software that was still in its infancy, needed a lot of work, but we acquired it because we had a foundation. And then with our clinical teams, we started to build that up. We started to build up the algorithms to make them robust, right? So we did look at these as capabilities. Then we acquired another organization that had patients that they serviced at home. So they had a patient population that lived at home. And it was a small organization, but they served as those advocates that I described, right?
Right.
They engaged with the patient on a regular basis. How are you doing? What's going on? How's your therapy? And it was also a pharmacy that sent meds to that patient. So it had the whole wraparound. Not only were we be your advocate, make sure you're on the right meds, speak to your doctor, make sure adjustments are necessary, we'll do them. But we will also be your pharmacy of record and send the meds to you. Then we combine these capabilities, right? So where the second company that I described that was sending the meds, they were doing it pharmacists manually. We said,
Right.
no, you don't have to. Now we got the software. So we put it together. So over time, it's been going after certain capabilities that we think are critical to really scale. And then we acquire those capabilities and put them into one. That's really how this has evolved.
Well, it's so interesting too, because the pharmacists, I mean, in a slightly different take on this, I mean, the number of pharmacists I've talked to who still use paper to manage their MTM, they have a paper calendar, and yet their system, you're describing a system here where they don't have to do that, right? This is going to be presented for them, and they're then able to use their expertise to make clinical decisions, as opposed to opening a binder and alphabetically and going and finding the patient and then, cross-referencing a calendar or something. I mean, I think that's the point of this technology in pharmacy, is to get away from these manual processes. I mean, there's just not enough time. And when you talk about patients that you're talking about, they're high risk. I mean, you need all that information right there for you to review.
I'll give you one other piece. I absolutely agree with everything you said. The other piece I'll tell you is just in terms of labor, you're talking efficiency and productivity. Imagine how many pharmacists you have to hire as this population is aging, right? The baby boomers are aging. There are so many people that need this kind of care. If we had the same old manual methods and paper-based methods, you'd be hiring, rooms and rooms full of pharmacists shifting through paperwork. And I'm not sure you could find enough pharmacists to be able to do all of that. Let's say you did. Let's say you found them, right? And they're willing to work for you and willing to do all of this. Well, how do you get pharmacist A and pharmacist D to do the same exact thing if you're going to use their judgment and paper? Because you may have one pharmacist that looked at it and say, in my view, this is how we should address the therapy need. And somebody could have some other way of doing it. And you never know. They might not be following the standard evidence-based guidelines. If you have it in a software and you have it embedded that way and the algorithms are built that way, and the output is really coming out, now you're giving the pharmacist specific action items, and on the back end it's standardized. So the quality and the level of care that each patient is receiving is equal. Right? It's not variable dependent upon if the person slept through biochem or medicinal chem that day, right? The pharmacist did. So it's standard. Obviously, I'm joking, but you understand what I mean.
I think it's really interesting also because, I mean, one of the topics we were going to talk about was the impact on healthcare costs. And I think that what you're talking about, which is standard care, not variable care based on the farm, because also, the reality is we were sort of joking about it, but there's not the same pharmacist in the pharmacy every day either, nor if you have a patient in a skilled or, in a facility, if you're, closed door or you're doing long-term care at home and you're delivering to a homebound patient, the same people are not involved all the time. So when you have this consistent care being provided, then that's going to reduce healthcare costs, because you're not going to have, like you're talking about labor, you're not going to talk about mistakes and packaging being returned. There are all these different ways that it's going to reduce healthcare costs.
Yeah, absolutely. I agree. But look, I break it down in terms of the impact on healthcare costs. There's three big buckets that I think about, right? One is, we talked about it before, the adherence bucket. Many people, including a lot of retail pharmacies, where, again, people can tell me I don't know what I'm talking about, but I worked a decade in that space. They measure adherence by, did you pick up your med, Meredith? If you picked up your meds, there you go. You're adherent. You're coming every month. You're picking up your meds, right? But I've worked I worked for an organization that did dialysis care, and I started their pharmacy for them. And we sent people into those patients' homes, and they opened up the cabinets. And yes, they were getting meds every month. but the cabinets are full of the
Not
medications,
taking
right?
them, right?
They're not taking them. So who measures that? Who is there to really truly measure compliance and adherence with the medication therapy? We do that. And we have ways and we have tricks to really understand if the drugs are being taken, right? And we are not just worried about dispensing and saying our job is done. So I think the impact of medication adherence is a straight line to the healthcare cost, right? That's one thing that you got to get down. Then there is the efficiency of the drug therapy. We have found people that we've talked to, and when we've done these interviews, we have found things that were undiagnosed that needed therapy. We found gaps in medication therapy. We found overlap drugs in medication therapy, right? So the lack of an effective therapy is creating issues and creating cost in the system that we can take out. And it's not necessarily, we have to think broader here. It's not just the old method of, oh, they were on 10 medications. I looked at it, I reduced it to 8. Look how much money I saved with the 2 meds I'm not taking now. We're not looking at that short-term tactical benefit. What we're looking at is the therapy right, because we firmly believe if the therapy is right, the larger healthcare cost will be reduced because of lack of reentry into a hospital and better outcomes for that patient. And the third piece we really look at, which is the third big bucket, right, is adverse events. And there's all kinds of statistics out there that you can research, but some say 25% of the patients that reentry into the hospital re-enter because of a med-related event, right? When they leave a hospital, they go home, they're taking a whole, different therapy, a lot of different medications, something interacts, they're back in again, right? How can we prevent that? Because that re-entry in the hospital is very costly, not financially, not just financially, let's say it that way, which is how maybe the payers look at it. It's tough for that patient. If you take an 80 or 90-year-old patient, take them from their home and have to put them back in a hospital for a stay, their health deteriorates during that period of time. So those are the 3 big buckets that we focus on. Now, there's a lot of sub-bullets down there in terms of things that we do, but if you can get those 3 big things right, you're headed in the right direction. Right.
How does the software work for closing the loop, so to speak? So how do you talk a lot about interviewing. So you are constantly talking to the patients and then putting their responses into inputting that data, and then that's obviously going into, creating helping the algorithm continue to evaluate the data overall for the medications and the medication therapy management. How does that happen? How do you find? I guess it's the equivalent of bidirectional information, right? This is coming from outside the system and going into the system.
Well, look, the system, as I told you before, starts with a set of core data, whereas pharmacy claims, lab claims, medical diagnosis, all of that stuff. And then you're right, we have inputs, which are the patient information. Once all that is in there, the algorithm churns and highlights key areas that we should really be focused on. Now, subsequent touches with that patient provide additional information. And when that additional information comes in, there's a reprioritization. Does something need to change? Are we still headed in the right direction? And that constant reprioritization is really what's beneficial. Now, the reprioritization is also based on the evidence-based guidelines. Let's say there's new literature that came out during the period of time since this last touch. Now, that is embedded in, and now the algorithms are churning based on new information. So if there's adjustments that need to be made, now the pharmacist is more aware, or the caregiver, whoever it is that's interacting with that patient is more aware because it's highlighted for them, the things that they need to address with that patient. So software is critical. I mean, I used to be a pretty good pharmacist. There's no way I could keep all this straight. It's really difficult, right? And I think when we look to scale this up, as I said before, with the aging population that we're seeing, we need tools like this to do it right.
Right. Especially as things like long-term care at home become
Yes.
standard, and pharmacists get more involved with that because, there is something of when you have everybody at one place, you have a facility in your system and you're working with that one facility. I wouldn't say it's easier, but it's, compact. You have all that information there. You can flag it by facility and look to see your patients there. But when you suddenly have all these diffuse locations with individual patients, having all that data in one place and having it prioritized for you, like you're saying, is going to be a huge time saver. I mean, you wouldn't be able to do it manually, probably. Like at a certain point, if you scaled up as a pharmacist, I don't see how you'd be able to handle all that without hiring.
I absolutely agree with what you're saying. So, let's fast forward and think of the environment that we're headed in. My parents aged at home because they didn't want to go into a nursing home. We were fortunate we could get them the care they needed so they could do that, right? I really don't want to go into a nursing home when I age, right?
Yeah, neither do my parents. So
there you go. So what you're seeing is a real shift in the population where when the nursing home industry came about, and there's a role that they play, which is critical, right? But now you see more and more people saying, I really want to age at home and I need tools to do it. The tools that have been available are really clinical tools, right? They've been physical therapists that'll go to the home. There'll be physicians or nurses that'll go to the home. But who's doing this kind of work in a scaled way, right? We have heard of pharmacists going into a home. That's certainly been there. Mm-hmm. But again, not with tools like this. So I think that as the environment changes and more people want to stay at home, to the point that you're making, that's a pretty complex environment. And it's a very diffuse environment, right? People are everywhere. How do you effectively manage that without tools? I think it's very difficult. And what we've done is we've created these tools that we think makes it easier, and not only easier for us, which allows us to scale, but it provides that standard of care for the patient also. So we think it's definitely needed in the marketplace.
Right. Well, that was one of the questions, was how you see medication therapy management evolving in long-term care pharmacy. And I think that's one of the real areas, is this long-term care at home, or, alternate, different settings. It doesn't necessarily have to be an individual. It can be a group home or such. But I think long-term care and the technology you're talking about is going to have a big impact, because people will be able to do this because the pharmacies will be able to provide the care, and also, I think we've been touching on this a lot, connect with other wider healthcare landscape providers and such.
Yeah, look, I agree. I think of it as the effective coordination of care. Mm-hmm. Without a holistic partner like ours, who is watching that patient and has the data of when they're in a skilled nursing facility, is watching that patient as they transition through the different stages and different places that they go, and rotating through them. We have visibility, right? There are many patients that we have today that we watch that are at home, that go into a hospital, that go into a nursing home for a period of time, and then they go back home again. Right. As they're going through that in certain markets, some of those patients are ours throughout that whole transition. That gives us the ability to really be an effective advocate and partner for that patient. And it gives data and information to the payer, who previously was getting retrospective data 90 days late in terms of claims, and then trying to sort it out, right? That doesn't work. Because if it's 90 days later, 3 months later, the amount of actions you can take are very delayed, right? Right. With patients with a lot of comorbidities that are in that high-risk population, actions need to be taken faster to get the best outcome. And I think us straddling across all these different points in that post-acute segment positions us as a great partner for a lot of these payers, because now we can effectively, in partnership with them, manage that patient from a med management standpoint.
Yeah, I mean, that's an area I'd like to actually hear a little bit more about, because the payer side of it, I think that's where pharmacy being able to be so connected is important. Like you're saying, you don't want to wait 3 months. Medication therapy management works on a monthly basis, basically, for most, or 2 weeks, depending on any sort of med changes. So this idea of being able to continue the loop on a more regular basis has to be a big win for payers also.
Yeah, look, I think the industry really started in a couple of different ways, right? Working with payers. The standard programs are the medication adherence programs, the Part D MTM programs, right, the STARS related initiatives. Those are just basic core programs, and those are the basic offerings that a lot of folks have. But those are back-end analytical based, right? There are organizations out there that have existed that will take a lot of that data on the back end, they'll churn it, and they'll give it to the health plan. Well, what's a health plan going to do with it at that point? Now, the health plan will, in many cases, hire somebody to say, okay, make some phone calls and try to get some shifts in therapy. Call the provider, call the patient, and shift. How many times do you pick up a call from a number that you don't recognize? Right? Oh, well, we'll go one step better. We'll send them an email or a letter. Well, that'll get it done, right? Right. So the best way to really do this is when you have that direct relationship with a patient and you are their pharmacy of record and you are engaging with them as it is anyway. So now all that information's coming in. We're doing the analytics back end. And instead of that health plan saying, let me hire a third person to go out and really engage with that patient, we have those tools also. So we are that singular partner. And then outside of the core programs, we have other programs, other specific clinical programs that we can layer on top, such as there is opiate therapy support program for folks that need it. There may be review of social determinants of health that may be preventing them from getting the right type of outcome. Polypharmacy is a real issue, right? Folks are going everywhere looking for the lowest price. It's Costco one day, it's CVS another day, somewhere else, right? Based on the medications and the price they can get for them. There's rheumatoid arthritis is a real issue. And there's specific programs we have around that and care there. So you take the core programs, then you layer on these clinical specific programs, and you've really got a holistic partner like us that can help manage that care for that patient.
Yeah, it's a robust clinical profile. I mean, you really can address. And the social determinants of health is pharmacy is really going to be front and center with that movement because many, especially when you look at this country and the rural areas, the pharmacies, their main healthcare contact on a regular basis. So the pharmacist being able to understand what might be preventing a patient from staying adherent and is key to this healthcare cost.
Yeah, you don't know how many patients we've talked to in rural settings where we talk to them about compliance and adherence. And after engagement, we find out, look, I'm just too old. I just can't get to the pharmacy that's so far away from me.
Right.
And that's why I haven't been taking my meds. And, we say, well, look, we're going to deliver it to your home for free. And it's a huge relief, right?
Right.
And there are people out there that can deliver at home for free. But again, they're checking the box. Oh, you need drugs? Which drug? Okay, you got it. They aren't partners in that care management like we are.
Right. And I think that, one of the final questions was, when we've talked about the different audiences that you address and work with, and, I don't know, actually, I can ask this question. I feel like you've really covered it, but, this healthcare journey and the various ways that you support the different audiences in this or the people, we have patients, we have pharmacists, we have skilled nursing staff, caregivers. All these people are part of this this healthcare journey. And it really feels like, from how you're describing all the services, and you've thought about all these people and how to make them connected.
Yeah, look, I don't think that the concept is a novel idea that we just came up with. A lot of people talk about doing things like this. And if you go into certain markets, there will be small entities that are doing something like this, right? And I think that's great. But with the population that we're talking about, especially the aging population, there needs to be mechanism to really scale this across the country. Because if you can effectively scale it, you can really take care of the population that's coming. These smaller players with more volume and without the tools I'm talking about will not be able to scale. So we have put those things together. We have done what I described, which is go out and say, this is a capability we're lacking. Let us acquire that capability or build it in-house so we can scale it. And it's critical. A lot of these physicians, providers that we speak to as we are advocates for that patient, they basically give us a call later and say, look, I got a couple more patients. I can see that they're struggling. They could really benefit from what you're doing. So, we've got providers that want to send us patients. We've got hospital systems that say, we're discharging patients and they're coming right back in. We know who they are and we know it's a med management issue. Can you help us? So there's a work stream, right? Those providers giving us. And then there's always the payer who's sitting there, again, looking at retrospective data, but they're sitting there looking at it and saying, hey, this population is really, really not adherent, is not on the right meds, their therapy's all wrong, and we see it in the cost. So I think there's a lot of different constituencies that are starting to see the value of what we can provide. And I didn't even mention the patient and their family yet, right?
Right.
Who see the greatest value in all of this. So we're very, very excited about the organization that we're putting together, the capabilities that we have, and our ability to scale this. We are one of the largest long-term care institutional pharmacies in the country. That was our core. And now with these additive services, our goal is to be not just viewed as institutional-based long-term care, but post-acute based long-term care. Because as you and I said, those patients are everywhere. Somebody's got to coordinate all of that.
That's amazing. And that's talking about the future of long-term care, right? I mean, it is. Our September, October issue we're working on now, that's the theme in general is, what are these trends in long-term care pharmacy and what technology solutions are coming out to support those changes and the innovation that's coming forward. And what you're talking about is that innovation of pulling all these different pieces together and making a holistic approach to it.
Absolutely. That's what we're attempting to do. And I think we are in very good position to scale this.
Mm-hmm. Well, great. I think we covered a lot, actually. I learned a lot.
Did.
Thank you for sharing all this. Do you have anything else you want to add before we?
Well, I mean, I think you just need to keep your fingers crossed and pray that the Phillies can turn this around and win again. Right? It's been too long. And don't forget about the Sixers. We've got a lot going on there too.
Right.
Other than that, I think things are good.
Good. Everything's good. If you could only manage the outcomes on the Phillies.
Yes. There you go. We haven't developed an algorithm for that yet.
Yes, you did. I think that'd be people would be very excited for that, at least in Philadelphia and the 191 area code.